Perfect. Okay, so let's start. Hello, everyone. I am Neeti Krishan, Assistant Professor at Khyati College of Physiotherapy, Ahmedabad. On behalf of Khyati College of Physiotherapy, I invite you all. So today's topic for webinar is manual therapy approach for herniated disc. So as we all know, as a physiotherapist, it's a common condition to deal with, yet very challenging. So today we have Dr. Joe Rosario, who will share his knowledge with us. So he is a physical therapist, acupuncturist, naturopath, and chiropractor as well. He has over 20 years of experience in a clinical as well as teaching field. He's developing a method to treat biomechanical problems through posture and myofascial release. So that is something very interesting, I must say. So, and plus he has also trained over 500 participants in the postural balance concept and methodology. And he's also an author of many books and chapters of books. And main aim or his research is mainly focused on clinical practice and aiming to achieve better results for patients. So students, let's grab this opportunity and let's learn something. Thank you. Over to you, Joe.
Thank you very much, Niti.
Yeah.
Good evening, everybody. It's a pleasure to be here and to talk to you today, to do this webinar. It's an amazing experience. I want to thank a lot Niti for the invitation, and let's share the presentation and let's start it. And I want to do something really special for you today. So I want this to be of relevancy for you. So I promise that you, in the end of this presentation, you'll be able to do something in your clinic. And it's totally online and you'll get it. Okay? All right, so let's start. Let's have fun now. So we are talking about manual therapy approach to herniated disc. So first of all, the thanks. Thanks for the Khyati College and the Khyati Institute of Physiotherapy, sorry. Special thanks to Dr. Dara Sharma and Niti Christian. And thanks also for Wi-Fi Mentor, because this is a class, it's excerpt of a class that it's in Wi-Fi Mentor. So thanks for them too, for allowing me to share this with you. So just a little bit of story from where I came. So I'm from Brazil, and I studied at the Federal University of São Carlos. That's the top 1 PT school in South America. And after that, I like to study, and I like to offer the best thing that I can to my patients. So I study acupuncture, chiropractic, osteopathy. I'm a specialist in posture. That's one of my fields, and I have a lot of passion about that. I have a PhD in psychobiology, another PhD in naturopathy. It's another passion. I'm also a yoga instructor, and we are talking mainly for Indians. And I wish to say that I really love all the contributions that the Indian culture gave to the world. It's amazing. And also I have 2 black belts, postdoctorate in psychobiology, and postdoctorate in behavioral medicine, several courses in Harvard, Wharton, and something like this. So another place like that. So how this course was created? Okay. So I am also the founder of the clinic franchise, the Doctor of the Spine. And as the name says, a lot of patients with back problems came to my clinic. And because I was a franchisee of the Doctor of the Spine as well. So because of the name, there's a lot of patients with back problems. and that's what I have to do. And I was in Brazil when I was over there. I still go there from time to time. And when I'm there, I am one of the most expensive practitioners of the country. So for this reason, the patients expect from me miracles. So I have to be really effective when I'm there, because I charge them. So they want the result. So they came to me like this, and they want to live like that as fast as possible. And so that I have to deliver a VIP, service to every patient. And that, so for this reason, I have to research a lot. Every problem, every case, I have to research. And that made me gave me a deeper understanding about spine problems, and that's what I'm going to share a little bit with you today, right? And one thing that I really like, it's like I said to you before, is that this must be something relevant. So if I'm not giving you value, I don't feel comfortable. So I don't want you to lose time with me. I don't want you to just hear me saying a lot of things. I want you to learn something and to take this and to have something useful, so you can apply that in your clinic, in your house. I don't know, we are in the middle of a pandemic, so maybe you are not in clinic, but you can use this. It's useful content. It's useful and practical material. All right. Okay. So let's start talking about back pain's impact on society, and that's really important. Why? Take a look on that, because that's exactly why I choose the name of my franchise. So the largest study done on the incidence of pathologies is the Global Burden of Disease, supported by the World Health Organization. And this study, and every time that I put some that I put the reference here, please, I will not keep talking about the reference, but if you want, you can take a picture, you can go after the reference, right? So this is study. It's very interesting because they put some ranks, some different ranks. So for the rank of
Study. And
lost years because of disability, in 1990 we have the backache in the 12th position. In 2010, the backache was in the 7th position. So you see, among all the problems, all the burdens, all the disabilities, backache, not just herniated disc, but backache is in the 7th position. So that's why it's important for us to understand, right? There's some curiosities here. The first position was ischemic heart disease. The second position, respiratory infections. The third disease is stroke. The fourth, diarrheal disease. The fifth, it's HIV. The sixth, malaria. So everything's pretty serious here. And you see, back pain is in the 7th position. And years lived with disability. So then, both in 90 and 2010, backaches in the first position. So did I convince you that it's important to know? Okay, if I don't, so let's give you a little bit more information about that. So the same article saying that back pain is the leading cause of disability in the world. It's responsible for 1/3 of the cases of world-related disability. It affects 9.4% of the population. It's in the first place in the list of pathologies of the item years suffering from disability. And the risk group, it's people between 35 and 65 years old. But the younger population it's starting to be in the risk group as well because of bad habits with cell phone and computer tablets and all the things that modernity brings to us, that good things and bad things, and that's one of the bad things. Well, another study published by the World Health Organization said that 80% of the world's population, I believe that we are like 7 billion people in the world today. I think that's more than that. And 80% of 7 billion people in the world will suffer at least one episode of back pain during the life. And at least 50% of people have some kind of back pain right now. So I don't know exactly how many people are watching us now. If it's like just in Zoom, it's the maximum capability. It's 100 people, 50 people. It's experienced some kind of back pain. So that's the importance. And not just the importance, because there's a lot of people suffering. But if you think about a clinic, a business, well, there's a lot of clients. You are not lacking any client, you see, because there's a lot of people in need of your service. So let's start talking about herniated disc, and let's start demystifying it a little bit, because usually when someone receives the notice from the doctor, okay, you have herniated disc, from some people it's like the life is over, and it's not like that. So let's talk a little bit about that. What is herniated disc? It's a displacement of disc material, nucleus pulposus or annulus fibrosus, beyond the intervertebral disc space, right? So this material goes out of the space of the intervertebral disc, okay? A little bit of anatomy, really fast. So when we talk about the anatomy of the vertebra, we have to consider two vertebrae. Because if we talk about manual therapy, right, two vertebrae it's very important because we need a joint. You see, we need to consider the joint. So we need at least a joint, obviously. So two vertebrae. What's important for us to notice here is that in the middle of the body of the vertebra, we have the nucleus pulposus, and surrounding the nucleus, we have the annulus fibrosus, right? So this is the intervertebral disc, right? And right behind the intervertebral disc, we have the spinal cord and the nerve root. So that's something that we should worry about. It seems that science is saying nowadays that probably the problem is not because of the nucleus pulposus get to the spinal cord or get to the nerve root. It seems that there is the internal innervation of the disc, that it's a problem, that it's the problem that it generates the pain. However, it's not 100%. It's not carved in stone yet. So let's take a look at that. Maybe in the future it changes again. I don't know. So it's interesting to have this in mind. And that's the problem that we can have when we are seeing a patient with a herniated disc. Okay. Well, and then we have the systematic review. And systematic review, for those of you that doesn't know, that don't know about what is a systematic review, I will explain really fast. A systematic review, it's in the top of the evidence, of the scientific evidence, because what they do, they are very rigorous to study and to review many of the scientific articles that we have today. Until the date of they done. For example, in this article here, it was in 2015. So this article said something really interesting. So there is a high prevalence of herniated discs among asymptomatic individuals. Disc degeneration is present in 90% of individuals aged 60 years or over. What does it mean? What does it mean? Let's take a look in another finding of the same study, and we will discuss everything together. So image findings of degenerative changes, such as disc degeneration, disc signal loss, disc height loss, disc protrusion, and facet arthropathy are usually part of the normal aging process rather than pathological process that require intervention. So that's normal. So probably a lot of you guys that you don't have anything, any symptom, probably you have herniated discs. So the same study again, 50% of the symptomatic individuals between 30 and 39 years have some degeneration, disc height loss or bulging disc. So it's normal. So it's asymptomatic individuals again, you see? So it's important for us to understand that when we do image, when you do, we get a patient with a magnetic resonance, and it has a herniated disc on it, not necessarily it's the cause of the problem, you see? So we are talking about something that it's really important, and it's really important for us to know, because there's a lot of people that are getting surgery to solve the herniated disc, but when the surgery is over, the pain is still there because it was not the herniated disc, you see? So that's very important for us to know. That's really important. So there's a part here. I have translated this presentation from Portuguese for you, and there's some mistakes here. So there's still Portuguese around. So just forget about it. The problem is that even in patients with low back pain, we have some degenerative findings, but it doesn't necessarily associate with the degree of the low back. So that's very interesting too. And it's the same thing all over again. Another studies in elite athletes show that there is no association between changes in the degenerative findings and the presence or intensity of low back. Again, you see? There is little evidence suggesting that medication as an effective treatment for herniated discs too. So that's very interesting, because I'm a physical therapist. You probably is a physical therapist too. Maybe there's other professions here. And it's very interesting because I have been in some medical congresses, for example, and when we are discussing about the herniated disc, the people, the doctors, the physicians that are they study, they are scientists also, they always say surgery is the last thing that you have to do, right? That's important. So the treatment must be the treatment that we do. That's the important thing. So science is saying that we can do the best care for our patients, right? We can do great things for them. So that's what science is saying. No medication is solving their problems. That's really important. Okay, a little bit more science about what we can do with our patients. So it seems that manipulation, and let me do some comment here, because what I said is that the name of this webinar, it's manual therapy approach for herniated discs. So for many people, manual therapy means manipulation. Here, what I'm saying, it's I'm taking a broader aspect, a broader approach to that. So everything that you do with your hands, for me right now in this presentation, is manual therapy, okay? So manipulation is one of the things that we can do with manual therapy for me, for us in this presentation right now, okay? So manipulation specifically is effective in relieving local or irradiating pain with people with acute back pain and sciatica with disc protrusion, and that's very interesting. But science has some concerns about the possibility of additional hernias, of appearing another hernia in people who are candidates for surgery. And if you do the manipulation in the wrong way, that's really possible. If you follow the right steps to the, if you go to the safer side, there is no problem, you see. But if you don't go in the safer side, you're a riskier manipulator, so maybe you'll have problems in some patients. So it's really important to understand what science is saying to us, and it's important to understand what it can do and what we cannot. Okay, bad rest. Bad rest, because when you have any kind of problem, the first thing that on some kind of pain, the first thing that we think, okay, let's take a rest. But not working, not for herniated disc. Bed rest is not an effective treatment for people with sciatica caused by herniated discs. And traction. Traction, it's very interesting. We have some like tables that are very expensive, and some people use, for example, in Brazil, we have like other franchise that use traction to treat herniated discs. However, it's not very effective for people with sciatica caused by herniated discs as well. So if you're thinking in treating herniated discs, don't spend your money with that, because that's very expensive and will not solve your problem or the problem of your patient. So forget about this, at least for now. That's what science has to say. So what do I do when I have a patient that has low back pain or herniated disc? And it's very interesting because many of the things that you have to do, it's similar. It doesn't matter if the patient has back pain, only back pain, normal, regular back pain. Back pain can be anything, can be the herniated disc, can be many other things, right? It can be including things that we don't treat, like kidney stones or pneumonia, for example. So we don't treat this. But for the regular musculoskeletal back pain and for the herniated discs, we have some very interesting things to do, right? So what do you do when you have a patient like that? So first of all, we have to evaluate. If we evaluate the patient well, so then we can make better choices, and we have better chances to solve his problem, right? So when we are evaluating, one thing that it's really important is to pay attention to the red flags. So red flags, what does this mean? And some things that you have to be aware of. For example, cancer. Cancer can be a very serious red flag. I talked about one red flag already. So red flags, what does this mean? And so there's a problem here with the sound. I'm hearing my own voice, so I'm sorry for the pause here. Okay, so kidney stones. Kidney stones is a red flag. So how can you discover if the patient has kidney stones? Well, if the kidney of the patient's here, you can make like a small percussion, okay? And this, if the patient starts screaming and crying, so probably he has a kidney stone, okay? Cancer. Cancer, you will understand if it's a cancer talking to the patient in your anamnesis, if he is waking at night because of the pain, probably it's a red flag. So be aware of that. It's good to take him to talk to a physician. So maybe it's not a patient for you. Also, if the patient has lost a lot of weight recently without any explanation, he's not increasing exercises, he's not making a diet, no explanation, another red flag. So pay attention to that and send the patient to a physician, right? So fracture. Fracture is also another red flag. The patient says that it has an accident, and you can use. I forgot the name in English. Is that thing that we use to tune the instrument. So you can use that. You can put over the bone that you were interested in doing all your evaluation. And if the patient feels pain with that, you see, you're just touching the instrument over the bone, and you can beat it, so it will start tremble and make a sound. Usually the la, right? Because it's a musical, it's used for tuning musical instruments. And so when the instrument that you put in the vertebra of the patient does something like, and the patient feels the pain, okay, that's a red flag. And it's a very interesting way of understanding when you have fracture, okay? All right, so what we can do if the patient has no red flags, it seems to be musculoskeletal pain, and maybe it's a herniated disc, maybe not, we're getting there. So even if the patient has bring to us an MRI, it's possible that the herniated disc has nothing to do with that pain. And we will talk a little bit about all of this, some hints that I can give you how to evaluate that. But now we are talking about some things that we can do to treat. So specific exercises are very interesting. And now I'm going to talk about one type of treatment that we can do. I'm not talking about all of them because I have just 1 hour to talk to you. Okay, so specific exercises are very interesting, right? But I don't have the time to explain a lot about them. But just for you to know that we have this, exercises can solve that. Vertebral manipulation, as we have talked earlier. So that's very interesting. That's not a topic that I chose to teach you today, because to teach manipulation online is really hard. Neural mobilization, that's very interesting too, okay? We have postural exercises. It's one of my fields of study, and I like it a lot. I have some courses about it, and it's very interesting, but it's not exactly what we are talking today too. Myofascial release, another one of my passions. It can really give a lot of problems. It can give back pain, normal back pain. It can produce is the same way that a bad posture can produce a herniated disc. The myofascial attachment can also produce the herniated disc as well. Pain and herniated discs, right? And trigger points. And that's what we are going to talk later. And it's really important, and you are going to learn this today, okay? So this is really important. If you don't know about if you know about trigger points, please stay with me, because it's always good to remember. If you don't know trigger points, I'm going to teach you how to treat using the trigger points, the logic that you can use to treat with the trigger points. But I really advise you to look for a course about trigger points, because that's really important. A clinician needs to know about how to treat with the trigger points, okay? How to treat the trigger points as well. So let's come back a little bit for our herniated disc before talking about trigger points. So it's very interesting, because we have to pay attention when the nucleus pulposus migrate, and about disc ruptures, okay? Some disc injury nomenclature that it's very interesting also for us to discuss, and for us to have a common ground when we are talking about that. So this, on your left, you can see the normal disc. In the middle, the second one, it's the bulging disc. It's not a hernia yet, right? The bulging disc, it's like the nucleus pulposus is doing pressure on the annulus fibrosus, but it's all around. It's not in one spot, right? Not like the protrusion or the extrusion. Both of them are hernias. So the protrusion, it's just in one part. that the annulus fibrosus, the nucleus pulposus, it's pressing the annulus fibrosus, and so we have a protrusion, but it's not the nucleus pulposus is not out yet. In the extrusion, yes, then the nucleus pulposus is out. And there is a very interesting exam too. It's the discogram. The discogram, we have grades to understand what's going on. We have the grade 0, that's the normal disc. Grade 1, it's not much of a problem. Grade 2, that can be painful. It's possible because of the innervation of the annulus fibrosus, okay? It's possible, but it's not guaranteed. Grade 3, well, maybe we have a problem not just with the innervation, but there's a possibility of hurting the innervation, the ganglion, the roots, the nerval roots, okay? Grade 4 is even worse, and grade 5, it's the sequestration. So maybe it's possible that the nucleus pulposus goes to another vertebra. It's not in the same level that he was originally. So that's, it's worrying, but maybe it doesn't do anything also. So it's very interesting. And here it's more or less the way that you see in discogram, and here is the discography. It's the discogram. It's the way that you can, that you receive this exam, right? Okay. And one important thing, and now we are going towards our evaluation. So if low back pain and referred pain, if the patient has low back pain and referred pain to the lower extremity, and it appears when the patient is in the CD position, and also when he is doing flexion, the trunk flexion, well, there's a likelihood that the symptoms is originating from a discogenic condition, okay? So that's very important for us to understand, because it's kind of a slump test. So we have to pay attention to that to understand what's going on. And it's very interesting. Please, if you think that a patient may have a herniated disc, and or it has an MRI or something like that, we can do the straight leg raise, and that's a very important test. Very cheap, because we do that on our clinic, and it's just amazing test. All right, when the test is negative, that's the important thing. When the test is negative, the chances to have a lumbar radiculopathy, it's very low. Okay, so when the test is negative, you can usually I don't know, we'll have some doctors that send the patient and saying, okay, you have to do surgery because you have a herniated disc. And when they come to me, I do the straight leg raise, and there are some other tests that are very similar that we can do, like LASEK too. It's the same rationale. And when it's negative, usually I say, okay, the problem is not your herniated disc. You see, that's the logic. So let's do something else, and don't try to go to the surgery, because it won't do you any good. You see, so let's try to see if we can heal in a non-invasive way, right? However, if you do the straight leg raise and you have a positive test, then chances are that you have a false positive. So you cannot think that because it's positive, you have a herniated disc compromising the situation. You see, the negative test, it's very strong for us to say, okay, probably you don't have a herniated disc giving you the problem that you're feeling, the pain that you're feeling. But when we have a positive test, we cannot think that it's the herniated disc for sure. Okay, is that clear? Right. So let's keep going. So let's keep talking. Let's start talking about the myofascial trigger point. what is a myofascial trigger point? According to Janet Travell, that's the physician of the President Kennedy, the iconic president from the United States. So she developed the theory of the myofascial trigger points, and according to her definition, its trigger point has been defined as a highly localized and hyper irritable spot in a palpable taut band in skeletal muscle fibers. Okay, so here in this image, it's very interesting because we can see this irritable spots in the muscle fibers. Let's go to the next slide so you can see it better. So you see, it's palpable. You have the taut bands here, right? It's like guitar strings. You can feel it. You can palpate it. It's normal, and you can feel like you can feel the trigger points as well. That's very important too. So you palpate it, and then you see around that you have relaxed muscle fibers, right? So that's very interesting. It has a very interesting palpation, and I suggest that as soon as the class ends, that you go and you try to palpate people, to palpate some of the points that we're going pinpoint here. Okay. And another thing that it's very interesting for us to understand is the disk biomechanics. I'm still talking about trigger points. It doesn't seem so, but it is, right? So as you can see here, when you move the disk, when you move the vertebra, the disk is pressed, it's pushed to some direction, right? How a trigger point can cause this? So you see, you have a contracted muscle, right? And when you have this the taut bands, when you have this, you change the joint position. And when you change the joint position, then you can have something like that. So the trigger point, you will see that the trigger point mimics pain. It mimics exactly the herniated disc pain, you see? However, it can also produce a real herniated disc. So that's why I choose the trigger point to teach to you today, because that's a very important entity for us to treat. So, and I'm sorry because there are some things in Portuguese here, and now we'll translate to you. Okay, so here we can have some very important things that you need to understand to so then when you have all of that, all this things that I'm going to talk to you right now, probably the patient has a trigger point. So it's very important for the evaluation, okay? So in blue here, you have a palpable taut band. So if the muscle is accessible, of course, there are some muscles that are not so accessible. For example, the iliopsoas, it will be really hard for you to find in taut band, okay? But other muscles, yeah, you can find it, and it's very interesting. In red, you see that we have like an exquisite spot of tenderness, like a nodule in this taut band. So we have to find this nodule, and this is very important. However, just finding the nodule doesn't need to be a trigger point. It can be something else. So it's interesting, we need to find the nodule, but we need something else. So in green, we'll have the painful limit to full stretch range of motion. Okay, because if you remember, we have this taut band, and the taut band it's taut. So it's really hard for the muscle to stretch, to fully stretch. And that's why we don't have the full range of motion too. So that's really important. You do stretch, for example, if it's in a leg, a muscle, a leg muscle, you can see in one leg and you can see in the other. You can compare both range of motion, and maybe the problem of the range of motion is related to the trigger point. So it's a sign that you have to be aware of. And in black, and that's really important for the active trigger point. And for a trigger point to give pain to someone, it needs to be active. If it's an inactive trigger point, it's still limiting the range of motion, and when I limit the range of motion, I can provoke the herniated disc, right? However, when I have the active trigger point, then the pain can come from, actually the pain can come from the trigger point, okay? So in black, we will notice, we will understand if the patient has the active trigger point or not. So that's really important. It's the patient pain recognition or comparable sign, and what that means. For example, it's very common for us to treat headaches with trigger point. So we have some points here in the sternocleidomastoideus muscle that give pain, and that's the way the pain does. It seems like a question mark. It can go all that way until the back of the eyes. So in any place, if the patient's feeling pain in any of those places, we have to be aware of. So it's a headache. It's an example. Of course, there's no relation with herniated disc, all right? But it's an example of how the trigger point works. And it's interesting because the trigger point's here. However, the pain's here. So that's very confusing for the patient, because what is the relation to that, right? And more than that, if we press the point, if we press the nodule that we palpate, and the patient says, oh, that's my pain, so my head's aching a lot, that's the patient pain recognition sign, all right? So that's very important. That's an active trigger point. And when we find that, okay, it's trigger point, let's treat it, all right? So the palpation for the trigger point, we have basically two types of palpation. So the flat palpation, you see there is the nodule, it's this ball under the skin, and so we go with our finger, and it's really important. So if you can look at me talking right now at my image, please take a look. We are going to do like this. It's a reasonable amount of pressure, all right? And we are not doing this, okay? We have to press, and then we have to do something like that. We go upward, downward, left direction, right direction. So this is really important, okay? So you can understand what's going on and you can find the nodule. So it's really important. Well, there are some muscles that I cannot use the flat palpation. The example that I gave, the muscle here, the sternocleidomastoideus, I have to do the pincer palpation. So I need to do something like that. If I want to evaluate the scalenus muscle, for example, that go underneath the sternocleidomastoideus, then I have to do the flat palpation, something like that. All right? Okay. So there is a very important rule after we treat the trigger point. So I will tell you how to treat it. I'll tell you the protocol, how we have to do it. But before we treat it, pardon me, please. After we treat it, we have to do the stretching. We have to stretch the muscle. It's part of the treatment, so we have to do it. And if you do the stretch and the patient feel any kind of pain in this muscle or in the other muscle, it doesn't need to be in the muscle that you have treated. It doesn't need let's get to the example that I gave you. So if we have the headache here, right? And I pressed the sternocleidomastoideus, the patient felt the pain here in the head, and then we treat it. and then the patient feel no pain at all. And then we're going to stretch it, for example, doing something like that. And the patient says, okay, I'm feeling the headache again. That's a positive stretch sign. Oh, I'm feeling a little bit discomfort here, and it's not just the feeling of a stretch, it's a kind of pain in the sternocleidomastoideus. So that's positive stretching sign. The patient can say, okay, I'm feeling some pain around here in the neck. That's positive stretching sign. Okay, so all of them are the same thing, positive stretching sign, right? So then what does it mean? It doesn't mean that the main trigger point, it was not deactivated, or the trigger point's not deactivated correctly, just a part of it. So you have to keep treating. The key trigger point is still active, all right? Okay, so treatment protocol, pay attention now. That's the most important part. So how you are going to treat the trigger point. So step one, you're going to do a progressive pressure release technique, all right? So you apply a gradual pressure, and then when you do a lot of pressure, because it's a lot, so you have to go deep. You see, you have to go deep, and when you do that, you have to stay at least 45 seconds. Okay, here is not a trigger point. Here it's an acupuncture point. Okay, but even though it's just the pressure that I want you to notice, right? Check with the patient if the pain is decreasing, and check if the nodule, it's decreasing, it's dissolving as well, okay? Then you can apply a little bit more pressure until the pain is significantly lowered or it disappears, all right? So that's our protocol. Sometimes we stay for more than 45 seconds, all right? Okay, step two, myofascial stretching. That's very important. We have talked about that, and that's why I talked about it before. So we will do a slow stretch, and it will stay there for 30 to 45 seconds per position. So if you are stretching in two directions, we're going to stay like 30, 45 seconds in each position, okay? We can combine it with breathing. So ask the patient to exhale, and when you're exhaling, the patient is exhaling, so then you can move the head and keep the stretch. You can go a little bit further, okay? And again, pay attention for the positive stretch sign. That's really important. If you forget to pay attention to the positive stretch sign, maybe you solve the pain of the patient, but in 5-10 minutes it will come back, right? And the patient will be angry, and then you will not be able to charge well for your services, okay? So that's very important. Okay, so let's take a look in some muscles that are relevant to the back pain and for the herniated discs. So these two muscles here, they mimic radiculopathy. So let's take a look about the draw of the referred pain pattern that they have, okay? So those muscles are ellipsoas and quadratus lumborum. Before we take a look at the muscles, take a look in the discogenic pain. So the discogenic pain can have more or less those patterns. There are 4 different patterns, and the last one is in the front of the thigh. So we can have pain in all these parts of the leg. So take a look in the ellipsoas and the quadratus lumborum. So the red part is the main part, the part where the patient probably will feel pain. It doesn't need to be exactly like that. It can be in just one spot. It doesn't need to be in the whole area. But there is a chance that the patient feel everything. And he or she can feel everything, and even when in the part there's the red dots, right? It's more unlikely, but you can have in these spots as well. So that's very interesting. You go into one part, including the front part of the thigh. Okay, so those muscles usually they are confounded with the radiculopathy because of that. So let's take a look on them. we have other muscles that go to the pain goes to the gastrocnemium, not the gastrocnemium. The gastrocnemium gives other types of pain. So, but the pain goes over there, exactly like a radiculopathy, lower radiculopathy. The here is not going so low, okay? But it's very interesting for us to take a look on that. Right. So first, ellipsoas. So the trigger point of ellipsoas, actually, we have three trigger points. So the first trigger point, you need to locate the umbilicus, and you locate also the iliac spine, right? Anterior superior iliac spine. And then in the middle of the way, you have the first trigger point in the midpoint, right? The second point you have in the the first one's more in the psoas than the iliacus. The second one is in the iliacus. So you have to go inside your iliac crest in the left side, in my left side, okay? Your right, my left. The iliac crest is here. You have to go inside the iliac crest and have to do something like this, and the trigger point is over here. Okay, and the third one is the one that it's described here. It's 2 finger breadth lateral the femur artery and 1 finger breadth below the inguinal ligament. Okay, so that's the third one. It's the hardest to find. Okay, and it's very interesting. So it's one thing that it's really important is even with those descriptions, you need to find the point. So I suggest that you, if you can, please try to find those points, those spots. The first one that I told you, it's really deep. It's behind the intestines. So you have to go really deep. And usually you need to do that in exhalation, because when the patient it's inspiring, is doing the inhalation, it's really hard for you to go there. If the patient starts to laugh also, not possible, because rectus abdominis will push you away. Okay, all right. After you got this all these points and you treat as we discussed, then we start stretching. How can we stretch? You can stretch with the patient in the lay down position, in supine position, or the patient can be kneel, half kneel. So you need a hip extension and a pelvic retroversion, or for hip stabilization, right? So both of these positions will work well, and you can do that for the patient, or you can do a home exercise. So you can teach the patient how to do those exercises at home too, so to avoid the trigger point to come back. All right, okay. Quadratus lumborum, another difficult muscle to get. All right, so I started with the 2 most difficult muscles. The others will be much easier than those. All right, why this muscle is difficult? Because you see, you have a small window to work. You have to go to the side, right? And you have to go that way. It's not, here is not my quadratus lumborum. It's down. Okay, I will do something here. That's smarter, right? So you have to do to the side, and you have to do something like that. Okay, so then you arrive at your quadratus lumborum. But pay attention to what I did. If I do something, let me do this. If I'm doing something like that, because I'm laying down at my side, in my left side, okay, here, then you can see my left side. So maybe I'm doing something like that. So what's happening? The ribs and the hips are doing something like that. So I cannot get my finger here. It's really difficult. So what should I do? I should do something different. I should position the patient, if I want to treat this side, must position the patient like that, so I can open the ribs, and I can put, again, I can put something over here, right in this side. So I will open the hip here and the ribs. And when I open, then I can go with my finger here, and then, you see, then I can palpate the quadratus lumborum. Once more, we'll do the flat palpation, and we'll do something like this. It's very important. For example, this muscle, the description, the classical description of this muscle, it has like several trigger points. So it's not just one or two, like we can see here in the picture. So there are many trigger points, so we have to search, all right? So there's not an exact location. We have to search. We go with our thumb, and then we go there, and you have really to, not so fast, but slower, and you have to do something like that, and to find all the trigger points, all right? And the stretching is really easy. It's just to do a contralateral side bending. It can be standing like I did. You can do this with your arms, so it will increase the power of the stretching. It can be on your knees. It can be side lying. So you have many options to stretch. Also, you can do, if, for example, if the patient, it's the trunk of the patient, it's the hip, the patient here. So if the patient does something like that, we can add some rotation to one side and rotation to the other side. Also, you get some different fibers of the quadratus lumborum. So that's interesting thing to do. Okay, so two stretching, all of them side bending to the same side, but rotation to one side, rotation to the other side a little bit, and then we will get different fibers, and it's really important, okay? All right. So the false sciatica and piriform syndrome. So we can treat the gluteus maximus and the piriformis, so that will be much easier now. And that's the referred pain pattern that the gluteus maximus and the piriformis can do, right? So we have to find all these spots. So the gluteus maximus, we have many different trigger points, and one thing that I really suggest, it's not get the definition, the trigger point that I gave here, but to try to locate in the whole area, right? So you can find, sometimes there are some points that are not in the map. Some patients can create something that it's new and it's normal. In the maps, you have the most common trigger points, but it can appear in other places as well. So it's interesting for you to search for them. But the one that it's described here, it's in the midway between greater trochanter and the sacrum. So that's very interesting because it's the same point of the piriformis too, the very same point. So there are some people discussing that the false sciatica made by the piriformis actually is not made by the piriformis, but actually it's made by the gluteus maximus, because the referred pain pattern is the same, right? So that's very interesting. But anyway, when you get this point, you'll treat both. So it doesn't matter actually which one it is, right? Stretching. To stretch, you need to do hip flexion and knee flexion. Very easy. And then you do. You can do it on supine position, like you have in the picture. You can also step in something. You are in the, I don't know, you are in the escalator, for example, and then you do something like that. Also, you put one foot like 3-4 steps higher, and then you can do the stretch as well. All right. Okay, just take care to not fall from the stairs, all right? So that's important too. Otherwise, if you're feeling insecure, supine position. The piriformis, same thing, midpoint between the posterior iliac, inferior iliac spine and the great trochanter. So it's more or less the same. If you see the TRP1, it's a little bit different. The TRP2, it's a little bit different, but the TRP1, which is the most common, and that's why I gave this description, it's more or less the same spot that we have with the gluteus maximus. So that's very interesting, and the treatment is pretty much the same. So after we press it, then we have to do our stretching. That's a very important part. So what we're going to do, the same thing that we did with gluteus maximus. We are doing the hip flexion, knee flexion, but also we are doing adduction and external rotation. The emphasis will be in the external rotation, all right? Okay, so more or less what she's doing in the picture here, it's the stretch for the piriformis. We have also sacral pain and radicular pattern. So here we have two very important muscles, very easy muscles to treat, not as difficult as the first two that I presented to you, the quadratus lumborum and the ellipsoas. So we have the gluteus medius and the gluteus minimus, and so that's the pain pattern. So you see that the gluteus minimus are very sciatic type, right? So if you are not sure if the other muscles have a relationship with that, they are mimicking correctly, well, the gluteus minimus, it's perfect, right? But the gluteus medius too, you have to pay attention to it because sometimes it's involved also. It's very important. The key trigger point may be, you have the key trigger point and the satellite's trigger point. So sometimes the satellite's trigger points doesn't need to be in the same muscle. They can be in other muscle. So for example, we can have a satellite's trigger points in the gluteus minimus giving a lot of pain, and the main trigger point, the key trigger point, in another muscle, usually in the area, okay? So for example, the gluteus medius or ellipsoas. And if you don't deactivate the main trigger point, the satellite trigger point will be around. You do the stretching and the pain will still be there. You see? That's the importance to find the key trigger point. Okay, so gluteus medius. The trigger point of the gluteus medius, it's really easy to find. It's 2 to 3 finger breadth below the midpoint of the outer surface of the iliac crest, right? So that's really easy. And then when you find, please search a little bit, play with the iliac crest, because usually we have the trigger point 1, the trigger point 2, the trigger point 3. They are all around there. So please search for it, all right? After you search, after you found, after you treat with the pressure, the digital pressure, the thumb pressure, so then what are you going to do? You're going to stretch. So hip flexion, knee flexion, adduction, and the emphasis this time is the adduction and sternal rotation also. So it's the same stretch that you did for the piriformis. However, the emphasis has changed. So it's not in the sternal rotation anymore, it's in the adduction, okay? And the gluteus minimus. So the gluteus minimus, it's a little below of the gluteus medius. So it's in the midway between the midpoint of the iliac crest and the great trochanter of the femur. So it's a little below. So if you, for example, if the iliac crest is here, the gluteus medius, you'll search around here. You see, the trochanter is here. So the gluteus minimus, you will search around here. It's a little below. Okay, the midpoint is very important. This line is very important, right in the middle. However, you have to search in all that area too, because it's possible to have more than one trigger point, as you can see in the picture, all right? And stretching is the same thing. So it's easy. If you have a hard time with the first two muscles, so this one, it's really easy. It's the same stretch, basically. So you need to do hip flexion, knee flexion, adduction, and the emphasis, like the gluteus medius, and external rotation. Okay, that's it. So that's all, folks. We have done for today, and I hope that you have enjoyed it. Please look for the trigger point. It's very interesting for me to teach so many content in a very short amount of time. I hope that you have understood the trigger points and how can you use it to treat the symptoms of herniated disc, or just a regular musculoskeletal lumbar low back pain. Okay, so it's really interesting, really important. If you didn't know the trigger points, so please know it, because it's very common, very. There's a lot of patients with that, so pay attention for the trigger points. I have something special for you guys. WiFiMentor.com. We have the herniated disc and lumbar pain online course. It's the full course. It's not. I need to hurry up here because I have just 1 hour to pass a lot of content to you. But in this course, there's a lot more content, and it's not ready yet. We are in the pre-launch, and there is a promotional value for that. So it's really inexpensive. It's like really cheap. I don't remember exactly, but I believe that it's for like $200. It's like 40 or something like that. So it's really interesting. It's a great promotion, and we will launch it in like 1 month or so. Okay, thank you very much for your attention. My contact information is here. If you have any kind of question, you can contact me there. You can send an email to me, and we'll have like more 15 minutes, so I will answer you some questions. And now we are going to organize how that's going to happen. So what you're going to do right now, it's if you have some questions, please go to the chat, write your question, because I'll read the question and I'll answer the question here. And please, I will answer them in the order until we have the time. We have more 15 minutes. So I will answer in the order. So if you have some questions, please hurry and go to the chat and do your question over there. If I'm not able to answer your question right now, so please send me an email, okay? So it's here, joe@manualtherapyacademy.ca, okay? All right, so now let's try to stop sharing here okay. So let's come back, and please, if you have some questions, you are free to make all of them, right? Written, please. Seeing
Hello,
someone.
Dr. Joe. It was a wonderful presentation. I am Dhara Sharma, and I'm principal at Khyati College of Physiotherapy. And it was a wonderful presentation, and all the insights that you gave on herniated disc and all the myofascia and all the trigger points and the elaborated clinical reasoning that you taught. That was wonderful. Students, if you have any questions, we can take it now. Please be quick and write your questions in the chat so that whatever time we are left with, he can, answer them.
Well, everybody's thinking about the questions. Thank you very much for the invitation. Thank you very much for this beautiful words that you have just said. And it's a pleasure for me. Anytime that you want for me to talk again for you guys, please, it will be a real pleasure. And I hope that I have contributed to your community in some way, in some extent.
That's so kind of you to say that. We are very grateful that, you accepted the invitation, and then you have offered your help again, that, we can invite you whenever again we have this opportunity for us to interact with our students. Yes, I'm sure students have benefited a lot out of whatever knowledge that you have shared with us. And in future, they are the budding physios. So when they would go out there in the community and start seeing the cases, I'm sure the knowledge that you have shared today, it is going to go a long way. So it was a pleasure, having you with us. Thank you so much.
Thank you. It's really important. I believe a lot in the job that we do with our hands to treat people that are in need, that have a lot of pain. And some of them are taking a lot of medications that have some nasty side effects. And we are saving people of all of that. So it's a beautiful profession. And we I like to teach people how to use their hands to make all this miracle happen. So for me, it's a real pleasure, and it's amazing. And I think that we have a question here.
Question.
So
Yes.
let's take a look. So the question is, can a patient end up having ecchymosis while getting the trigger point released? And if that happens, then should the therapist continue further with the release? So yeah, that's possible, and not just ecchymosis. It's possible to have some other situations. It's possible to have some black and blues because of some vases that it's not, it's unusual, it's not normal, but it's possible. And yeah, we can continue to further release if the patient the patient will feel some pain, but there is no problem. We don't need to stop the treatment in the middle. Actually, it's not a good idea to stop the treatment in the middle, because if you don't deactivate the point, it has a huge chance of getting worse. And then the pain is not only the treatment will not only be ineffective, but actually you'll harm a little bit the patient. So if you started, if you go really deep, continue until it ends. Okay, that's really important too. Thank you very much, Nisha, for your question. It's great one.
There was one more question which we came which has come on Facebook Live. We are also on Facebook Live, so there's a question that was asked there that can we differentiate the referred pain and the neurological pain without palpation?
Okay, yes, we can. And actually, we have this tool in the presentation. It's one of the tools, okay? So the straight leg raise, it's a very important diagnostic tools that we can have it. So if it's positive, okay. If it's negative, so it's a great indication that it's not a neurological pain. If it's positive, we cannot say that it's a neurological pain. However, it's possible. We can do other tests, but it's like the same test. It's not 100% secure, but there's a bigger chance. So that test, it's really important. So if you have to choose just one test to do, choose this test and do that. Straight leg raise or the Lazag. The Lazag is more or less the same. So for example, the straight leg raise, this is the leg, okay? And this is the knee. My elbow is the knee, all right? The straight leg raise, we do something like that directly. The Lazag, it's the same thing, the same rationale. So, but we start with, we have like 60 degrees here, right, with hip flexion, and then we will extend the knee, right? So that's a text, the test. So that's the difference between Lazag and the straight leg raise. So you can do both, just in case, but usually just one's enough. All right. Thank you for this question too. It's a very good.
Thank you. I guess that's about it.
All right. All right. Well, if there is no more questions, maybe that's time for well, people, I will write here my email also, because it will make easier for everybody if they want to send me email to send other questions. I will happy to answer all of them. So it's joe@manualtherapyacademy.ca. Please contact me. So that will be a pleasure for me once more. And sometimes I take a while to answer all the emails, but again, I promise that I will answer each one of them. So if you don't have any other questions for now, so again, thank you very much. Thank you, thank your institution. It's all amazing. It's an amazing opportunity in the middle of the pandemic for doing something nice for everybody. And please feel free to ask me whatever you want. And please, all of you, stay safe, okay? Because we are health professionals. Sometimes we have to expose ourselves to treat others, but if you're not treating others, please don't take this lightly. We haven't seen, I'm from Brazil. In Brazil, for example, it's horrible. That's a lot of people dying over there. So please take care of that. In Canada is better, but anyway, there are people dying too. So please be safe. And if you are seeing patients, talk to them and teach them how to be safe also, because those are dark times. And I'm glad that I can do something for you in the middle of all that. All right.
Thank you. Thank you so much again. I mean, in times like these, I feel technology is a boon where we could, connect to people sitting the other end of the globe. So, otherwise, without the pandemic, probably we wouldn't have think of this. But I think it's probably like blessing in disguise. That's how I take it positively.
Yep.
So, yes,
Agree.
once again, thank you so much for sparing your time and sharing this knowledge with our students. I would like to thank all the people who are watching us live on the Facebook also. Thank you. Thank you so much.
Thank you, all of you, very much. Be well, be safe, everybody. Thanks.